Good afternoon, everyone. My name is Chelsea Lynch from NQS. Thank you for joining us. Please review the housekeeping reminders and we'll get started in just a minute. Okay, and I think we are ready to get started. Victoria, if you could advance to the next slide, please. Hello, everyone. I know it's 13 days past the new year, but Happy New Year. I'm really excited to start 2022 with all of you. And welcome to the second web meeting of the Leveraging EHR Source Measures to Improve Care Communication and Coordination Option Year. My name is Chelsea Lynch, and I'm a Director in Emerging Initiatives at the National Quality Forum. We truly appreciate that all of you joined us today and that all of you are prioritizing this work within your busy schedules. Additionally, we'd like to thank CMS for funding this important work. I'm really looking forward to our discussions today as we further identify and refine recommendations to improve and measure EHR-based care communication and care coordination. Before we get started, I'd like to share a few housekeeping reminders. Today and the next couple of meetings, we are using the Zoom platform, which has audio and video capabilities as well as a breakout group function. Please place yourself on mute when you're not speaking, and we encourage you to keep your video on, especially when you are speaking. Please ensure your name is displayed correctly. If needed, you can edit your name by right-clicking on your picture and selecting Rename, and you can also switch your display by right-clicking View on the upper right-hand corner and selecting Speaker or Gallery. As always, please feel free to use the chat box to communicate with NQS staff and with each other, and please use the raise hand feature during discussions to be called upon to speak. We'll take committee attendance shortly. Next slide. I would like to invite our wonderful co-chairs, Dr. Richard Antonelli and Dr. Jerry Lamb, to share any additional welcoming remarks. Jerry, how about we start with you today?
Okay, and I remembered to take myself off mute, so I win. Welcome, everybody. It's really wonderful to see you. It's so exciting to be moving into the recommendation phase of our option year. So looking forward to the work ahead and to our breakout groups. And just a quick reminder, if you don't have your worksheet in front of you, if you could get it, that would be fabulous so that we can see each other. Rich?
Thank you, Jerry. Thanks to NQF staff for putting this together so efficiently and effectively, and of course to CMS for your confidence in funding. And so the committee, there's a very intentional reason that we're using breakouts today. We want to give you, each of the members, as much airtime as possible to inform this work. This option year, it is, we want it to come from each of you, give us the views that we might be missing, focus on functionality, in this space, capacity building. So I'm really excited about today because it is setting the stage for the work ahead. So please do not be shy, get into the breakout groups and share your ideas. So welcome to everybody.
Thank you both so much. Next slide, please. I'll briefly go over our agenda for today. After covering our objectives for today's meeting and taking attendance, we'll provide a brief overview on some select background resources to help set the stage for our discussions today. We'll then move into a working session where we'll break out into two groups to discuss recommendations for how to effectively facilitate care communication and care coordination with EHRs. After we hear the reports from those sessions, we'll have a few minutes for NQF member and public comments, and we'll wrap up with next steps. Next slide. So we'll get started with an overview of our meeting objectives and attendance. We'll start with an overview of the project timeline. As a reminder, we have a total of 6 web meetings, and the focus of the first 4 is to develop recommendations. In today's meeting, we'll be focusing on refining recommendations related to how EHRs can better facilitate care communication and care coordination. So really digging into how a good EHR could function and which capabilities and capacities are essential for effective care communication and care coordination. In our February meeting, we'll be exploring recommendations related to social determinants of health data within EHRs and how to use it to optimize the measurement of care communication and care coordination. And then in our March web meeting, we'll be focusing on developing recommendations about how existing and future development of EHR source measures can be leveraged to improve care communication and care coordination and develop some possible measure concepts. Web meetings 5 and 6, we will be reviewing and refining the recommendations and the 2 final recommendations reports based on committee feedback and public comments. Next slide. So as I mentioned, the objectives for today's meeting are to review and provide a brief overview on select background resources that will help frame our discussion as we refine and finalize recommendations for how EHRs could better facilitate care communication and care coordination. I'm now going to hand it over to Victoria to take attendance. If you are not able to join our first web meeting in November, please take this opportunity to introduce yourself as well as verbally share your disclosures of interest or simply state you have nothing to disclose. Victoria?
Thank you, Chelsea. I will start with our co-chairs, Richard Antonelli.
Present and nothing to disclose.
Thank you, Rich. I will go on to Jerry Lamb.
I'm here and nothing to disclose.
Thank you, Jerry. Kathleen Balstracci.
Yes, hi, I'm here and nothing to disclose.
Thank you. David Burianic. Okay. Next, Brian Bies. Okay. Sherry Costa. Okay. Cynthia Cullen.
Hi there, Cindy Cullen, please. Same disclosure as before, which is I oversee a portfolio of projects that are sponsored by CMS.
Thank you, Cindy. Next.
Victoria, this is Jerry. I'm seeing some of the names on screen that we're not hearing. And so if we could just check if people's videos are working or audio, because Sherry Costa is on screen, so is David. So I don't know that I heard that they responded.
This is
Okay.
Dave Burianic. Did you hear me? Can you hear me now?
Oh, there we go. We can hear you.
Oh, okay. Yep, I'm here.
Thank
Nothing to
you.
disclose. Thanks.
Thank you,
Hi,
David.
Sherry. Hi, Sherry Custer's here too. I'm rebooting my computer, so I'm here and nothing to disclose.
Thank you, Sherry. Okay. Let me go back for a second. Was Brian Bies on the call? Okay. Still haven't heard from him. Okay, I will move back on down to Keith Horvath.
Present and nothing to disclose.
Thank you. David Key. Okay, moving on down, Joseph Kumich.
Present and nothing to disclose.
Okay, thank you. Russell Leftwich.
He sent us a note that he will be about an
Yes.
hour late.
Okay,
We are
yes, you were
planning on
right.
joining, but yeah, thanks.
Michael Lieberman. Brent Perry.
Present and nothing to disclose.
Thank you. Rebecca Perez.
Present and nothing to disclose.
Thank you. Ann Pollock.
Present and nothing to disclose.
Thank you. Walter Rosenberg.
Present, nothing to disclose.
Thank you. Stacy Schilling.
Yes, hi, I'm here. I, like Cindy, work on a number of CMS projects for hospital patient safety measures, the Kidney Care Choices model, and I also have funding from the Moore Foundation for diagnostic excellence measures. However, none of those are directly relevant or pose any conflict for EHR care coordination or communication.
Thank you, Stacy. Sue Ellen Shea.
Sorry, I'm trying to find the mute button.
There you go.
I am here, and the only thing I have to disclose, I work for Cerner on the government side as a clinical consultant.
Thank you.
Huh?
Colleen Scow.
I'm here. I have nothing to disclose.
Thank you. Alexis Snyder.
Hi, I'm here. No conflicts.
Thank you. Maureen Stewart. Jason Weisner. Dorothy Winningham.
I'm here and nothing to disclose.
Thank you, Dorothy. Kim Yu. I believe she told us she wouldn't be on today. And Andrew Zinkel. Okay, if I missed anyone on the roster or they didn't get a chance to unmute themselves, take this moment. Okay, thank you. I will now allow our federal liaisons a chance to identify themselves, unmute themselves. I'll start with Joel Andrus. Okay, move on to Tiffany Gillis Brown. Kyle Cobb.
Hi there, I'm present.
Thank you. Chris Dimick.
Hello, Happy New Year, everyone.
Happy New Year. I will go down to Tara McMillan, and she said she would not be here. Carly Madosh. Francine Sandro.
Hi, I'm here.
Thank you. And Kenneth Yale. Okay, thank you. And Chelsea, I'll give it back to you.
Thank you so much, Victoria, and thank you all again for joining us this afternoon. I'm very fortunate to be joined by a great team here working on the project. I'd like to thank Udara, Monica, Victoria, and Jesse for all of their hard work and support. Additionally, I'd like to acknowledge some additional support from Chuck, Carol, Mara, and the IT team at NQF for their help with facilitating and running today's meeting. Next slide. I'd also like to acknowledge and thank Kim Rawlings and DeQuincia Pope from CMS for their support on this project as well. And next slide. And as always, before we get started, I'll quickly go over some ground rules for our meeting today. As you know, we want to emphasize that there is no rank in this room. Everyone's opinion and insight is valuable. This is a complex topic, so your experiences are critical to the advancement of our work. Please share your experiences and learn from one another. Be respectful to other committee members, create space for different perspectives. Additionally, please refrain from making any political jokes or comments. Next slide, please. So before we begin today's working session, we wanted to provide a brief overview of some background resources that might be helpful. During our first web meeting in November, a few key concepts came up during the discussion, and we shared a background resource document with additional information about those concepts. Today, we will be getting into a lot of detail about these concepts, and full comprehension of these topics are not required to be able to participate in today's meeting. But we think having at least a basic understanding of what these concepts are will be helpful to ensure the recommendations we develop are detailed, practical, and will be able to help advance the field forward. Next slide. One of the major concepts that is essential for our work is interoperability, which is the ability to share information easily between different systems. To help frame our discussion today, this is how we're thinking about interoperability and how it relates to having effective EHR-based care communication and care coordination. To have an EHR that is optimized for care communication and care coordination functions that is also considered usable by stakeholders, interoperable data within the EHR is essential. Next slide. However, there's already a lot of work being performed to set data standards and move towards fully interoperable systems, and we don't want to spend time recreating the wheel. We definitely need to consider interoperability when developing our recommendations, but we don't want to be constrained by it. So during our discussions today, we want to focus on EHR functionalities, capabilities, and capacities that lead to usable EHRs by various stakeholders. And we'll approach our recommendations through the lens of 3 stages of interoperability, which I'll describe on the next slide. Our hope is in using the lens of 3 stages of interoperability, we'll be able to develop practical recommendations for our current state, while also not restricting us from making recommendations for an ideal future state. Next slide. On this slide, we've laid out how we're approaching the stages of interoperability. We have early, intermediate, and advanced stages. These are not clearly distinct stages, and it's possible there might be some overlap. In the early stages of interoperability, we're considering things like starting to improve existing health IT networks and beginning to standardize vocabulary. In intermediate, we're starting to expand the information that's being exchanged, as well as the number of providers that are participating, and starting to aggregate data across entities to manage quality and equity. In advanced interoperability, the systems are continuously learning and improving functionality and using aggregated data along with local data to create clinical decision support. Again, this is just a structure for us to use as we approach the complexities of interoperability while developing recommendations. Next slide. As I mentioned, there's a lot of work that's already being performed in attempts to solve interoperability. I'm going to highlight a few of them here, particularly because I think these concepts may come up during our discussion and want to ensure there's a basic understanding of what we're referring to. The first is the United States Core Data for Interoperability, or USEDI. This establishes a standard set of data classes and data elements for nationwide interoperable health information exchange. This data set has been under standard and rulemaking development for over 10 years, and its use is mandated by the Office of the National Coordinator for Health Information Technology, or ONC, as well as CMS to ensure improved healthcare information interoperability. It includes data classes such as assessment and plan of treatment, care team members, clinical notes, and goals. Next slide. Next, we have the Health Level 7 Fast Healthcare Interoperability Resources, or FHIR. FHIR is an internet-based approach to transferring and sharing health information to provide seamless interoperability and patient-centered data-driven care. It is a representational state API that includes the specifications for how one system requests and receives data. It includes resources which are discrete data concepts such as patient information, family history, and medication lists. And it also includes profiles, which are use cases that tell the relationship and provide meaning to the resources. ONC and CMS both have rules that are requiring implementation of FHIR-based APIs to support the sharing of health information, and this implementation will also help move the field towards digital quality measurement. Next slide. I also want to mention health information exchanges, or HIEs. These are centralized databases or portals that combine EHR data from multiple sources to assist in data standardization and information sharing across settings. There are 3 key forms of HIE: direct exchange, where information is shared between care providers to support coordinated care; query-based exchange where providers can find or request information on the patient from another provider, and consumer-mediated exchange where patients can aggregate and control the use of their health information among providers. Next slide. And finally, we have the application programming interfaces, or APIs. These are a set of defined rules that explain how computers or applications can communicate with one another. They sit between an application and the web server, and they allow services and products to communicate with each other and leverage each other's data and functionality through a documented interface. An example of an API is a travel booking website like Travelocity or Orbitz, where they aggregate data from websites of various airlines or car rental agencies into one platform. So before we transition to the next section, are there any questions, or if any of our experts have any refinements to the very basic information that I shared, please feel free to raise your hand, or you can also just unmute. And we can go to the next slide.
Hi, this is Kyle Cobb. I was just going to make a clarification around USCDI. It is built on another core data set, but it has not been around for 10 years. So USCDI version 1 was, it is new. So I wanted to make sure that that was updated. And in terms of interoperability and sort of its general application, the US Core Implementation Guide, which is the FHIR implementation guide, which is part of the ONC certification criteria, uses the USCDI data elements. So, and I'm happy to spend some time walking people through that, but that's just an important connection there. And I, short of Joel being here, I think we can speak a little bit to the fact that there is also something called USCDI Plus, which is a advanced or a specific version of USCDI that ONC is starting to work on with CMS. It's called USCDI Plus QM to support quality measurement efforts that are part of the transformation of quality measures to reporting to a FHIR-based digital quality model.
Thank you so much, Kyle. And I will have to, I apologize that my reference said it was 10 years. So thank you, definitely thank you for correcting that. And
for sure.
I think for the purposes of the committee, maybe at a future meeting, it might be helpful to kind of get a little bit more detail, or we may follow up with that level of detail, that technical information offline. We certainly want to make sure our reports are reflecting the current state and obviously the correct information as well.
Absolutely.
And I really appreciate your feedback.
Sure.
And I know you and Joel both have really great perspectives on the technical aspects of this. So thank you.
And P.S., we're also working pretty closely with each other on this. So yeah.
Which works out really well for our committee, I think. Are there any other questions or any additional background resources that the committee thinks might be helpful? Again, we're trying to we definitely want to make sure we are considering the current state and interoperability and all of those details. But as you mentioned, Kyle with ONC and CMS, as well as a whole group of other people are really working on figuring out those data sets and data standards. So we really want to focus on what would be really helpful for the EHR to have in order for them to even move forward with some of these pieces in terms of moving towards improving care coordination, as well as moving towards that digital quality measurement. So seeing no hands raised or comments in the chat, I think we can go ahead and move on to our next section. So shortly, we'll be breaking out into two groups to refine and finalize recommendations for how EHRs can effectively facilitate care communication and care coordination. Next slide. During the breakout groups, we'll be reviewing recommendations by theme. These themes are collect and share data, optimize usability for clinicians and patients, document performance of care communication and coordination activities, and assess the quality and performance of care communication and care coordination activities. These recommendations come from our discussions during the base year, during the development of the literature review and environmental scan report, as well as our discussions at the first web meeting. We'll really be digging into themes in further detail during the breakout groups, but wanted just to provide a quick overview of each. And hopefully this should all sound familiar if you looked at your worksheet in advance of the meeting. Next slide. So for the collect and share data theme, for EHRs to effectively facilitate care communication and care coordination, they must be able to do things such as intake data from systems where patients receive care, transfer data to local HIEs, and communicate with various applications while also allowing patients to control the sharing of their information. Next slide. For the optimized usability for clinicians and patients theme, for EHRs to effectively facilitate care communication and care coordination, they must be able to do things such as summarize specific data elements in an easily accessible and user-friendly manner, and highlight when aspects of a care plan are not followed, such as when a treatment or a follow-up test is not obtained. Next slide. For the document performance of care communication and care coordination activity theme, for EHRs to effectively facilitate care communication and care coordination, they must be able to do things such as creating customized alerts, develop and implement customized care plans, and allow for real-time HIPAA-compliant communication among the care team, including with patients. And next slide. For the assess the quality and performance of care communication and care coordination activities theme, for EHRs to effectively facilitate care communication and care coordination, they must be able to do things such as assess if a care plan was created, as well as followed, and allow for the monitoring of care quality through queries and performance measures. And next slide. So again, we'll dig into all of those things in greater detail in just a few minutes, but before we transition to the breakout sessions, I did want to just kind of cover the intent and how the sessions will run. Next slide. So as Rich mentioned, we're using the breakout sessions to allow for more in-depth discussion on these recommendations and to make space to hear everyone's thoughts and perspectives. So each person on the committee and the federal liaisons will be assigned to a breakout group with one of the co-chairs and a couple of NQS staff. We'll have about 60 minutes to brainstorm and discuss the 4 sets of recommendations for how EHRs can effectively facilitate care communication and care coordination. We'll then come back together for a report out from the session and discuss any final points as a group. If for some reason you get disconnected or have any technical issues, we have NQS staff available to help provide assistance or to ensure that you get placed into the correct group. Next slide. So the breakout assignments are on the screen, but no need for you to worry about where you will end up. You will shortly be automatically placed into the correct group by our IT team. Our federal liaisons and committee members have been assigned, and then members of the public, we will get you dispersed. It just may take a little bit longer, but as soon as our IT team is ready, we will get you into the group and we'll get started.
Chelsea, quick question. For
Yes.
folks who are joining late, how will they get into the groups?
So there will be somebody within who stays in the this main session, and they will be able to put them in and let them know this is what's going on and we're putting you in the right place. And same as if somebody gets disconnected, there's a few people who will be staying in this main section.
Perfect, thank you.
And Welcome back, everyone. We'll give just a few more minutes until give everybody, some time to come back. And I think we have everyone. Rich and Jerry, not sure, do you want us to share the slide with the intent of the breakout, or would you prefer keeping the slides down just in case there's some additional discussion?
Speaking from Breakout Group 1, I think people were pretty familiar with the bullet points and stuff, and everybody had their worksheets in front of them. So I would vote for keeping face on screen.
I agree.
Okay, perfect. So we will go ahead and do our report outs, and we'll start with Breakout Group 1, which I believe is yours, Jerry.
Okay. I thought Rich was going first. This is not fair, Chelsea.
I mean, we can go alphabetical by last name, that's fine.
It's okay. All right. So my understanding was we're going to lay out our the recommendations, and then we'll have that discussion. So, all right, Breakout Group 1, I'm going to start, going to leave at least a minute or two. So if I forget anything, you holler. Okay, 2 to 3 recommendations that should be refined or excluded. Okay, we did not exclude anything. We really focused on refinements and expansions. The things we talked about is one of the foundational things is common data definitions. Okay, and then specifying the connections between EHR and other data sources. And in particular, we talked about, as we look at EHR, the connections to HIE, lab data, immunizations, and making sure that we have that in the report that we also talk about other databases. We had a huge emphasis in our discussion about patients and how they use data. Okay, understanding that all of us are patients, but how patients do use data, how patients want to interact with the EHR. As a breakout group, we felt that our recommendations came in kind of short related to functionality and usability for patients, and that we needed to explore meaningful data to patients that was in particular actionable and able to prioritize. Along those lines, Kyle filled us in on what ONC requires of patient portals and felt that that should be an important context here. Recommendations based on interoperability stages. While we focused on the here and now and functionality, we also thought for down the road, okay, in the words of one of our group members, we need to get to the place where patients input their own data, use their own data, learn from their own data. And that we need to be looking at, and this is a missing capacity, which is standardized structured fields for patient entry, as well as a recommendation to look at UX design applied for patients from the portal designs so that they are not so difficult to use. So a lot of emphasis on the how of patients interacting. We did a good job, we felt, a good starting job on usability and functionality for clinicians, not so much with patients. So the capabilities and capacities missing from the list were, we wanted to put some more time and effort into what are the standardized data elements for care coordination and care communication, both from structured and unstructured fields. How do we use qualitative data better? how do we get care planning into meaningful data that doesn't get lost? We wanted to call out and separate out, identifying the, there was one document, one bullet point related to care teams, is to really focus on that. How do we make the invisible visible there? And how do we get the right data at the right time to the right people? And I think I hit the rest. So group one, what did I miss? What else would you like to call out?
Perfectly.
Yeah, and my only recommendation was the customized alerts piece, to approach that with caution.
Thanks, Sue Ellen. Anything else? Anything missed? God bless Victoria, who took notes. Okay, that's us. Rich, group two.
Right. Group two. So somehow Alexa Snyder managed to participate in both groups simultaneously. I'd love to know how she did that. So I will not repeat all of the comments. I don't think that there's one that you raised, Jerry, that your group pointed out that we didn't touch on. So I want to be time efficient here. So I'll just maybe emphasize a couple of points. But our team really pointed out this notion of having patients the ability to provide data in a meaningful way, and in particular, flagging information that they don't necessarily agree with or is actually flagrantly incorrect. Timeliness of information. So patients going to different locations for care in a relatively short period of time. Sometimes many institutions already have so-called ADT, admission, discharge, transfer reports, but they often are not nearly timely enough. So we talked about that. We talked also about the essential need to define data elements, particular health-related social needs and SDOH. So that's all I'll say about that. The lack of interoperability is a big pain point for families, not because it's not convenient, but for the patients and families and the caregivers. They're the ones that actually have to try to get the left hand and the right hand to communicate. And so fragmentation applies a significant burden to families. And I track the pediatric literature very well here, and I can tell you it results in broken marriages, it results in kids not going to school, and the parents and caregivers pulling out of the workforce. So there are economic and significant equity outcomes because of a burden on families for trying to defragment care. The identification of the care team is absolutely worth bringing that forward. The points were made that it may not just be everybody who is in that particular clinic. The family may view the school nurse or a behavioral counselor or a housing coordinator as being essential to their overall health outcomes. And that brings us into this notion of integration. Being able to not just identify members of the care team as defined by body organ system or where they are located geographically, their subspecialty, if you will, but even functionally. And that sometimes the integrator is another family member or the patient themselves. So how can we leverage and honor with appropriate care communication and care coordination functionality, the role of an integrator? This is especially important for patients that have complex needs, medical, social, behavioral, and developmental, and to actually have included in that care team who is playing that role as the integrator. I think probably just two more, and then I'll open it up to my team. This ability to identify what is missing and to have the patient family have a view of that will inform true patient engagement and patient centeredness. In other words, it should be a jointly defined care team, a jointly defined plan of care, and that in fact, this will support shared decision making. And by the way, just in terms of measurement, shared decision making and care integration, we have outcome measures for those, especially the latter. And then one of our committee members talked about, all right, when we screen people for food insecurity, we make a referral. We don't know if they ever got there. And so there is a fundamental gap that is going to be exacerbated as we move out of the medical silo into the community health space, which is that opportunity to close the loop when making referrals. So that is in our the fourth domain around measurement. The ability to make a referral, make sure the patient got the resource that attracts to the care plan. That is, if you will, the life cycle of well-done care coordination. So before I open it up for a broader discussion, I'll open it up to my committee members and thank each of you. I think everybody weighed in. I'm grateful and proud. Anybody want to add anything? All right, then I think we can open it up. Chelsea, do I hand it to you?
We can just, if either group, hearing the report out from the other group, anything that kind of jogs something new that you want to share or really highlight that you think is incredibly important, certainly open to having the floor open for that. Or anything new that just popped up that you just can't wait to share. Or if you're sleeping later, you can email us tomorrow morning to share it too.
Two things strike me listening to group 2. First off, we had a discussion in group 1 about the importance of looking at functionality from a how perspective. How does this work? How is it functional? But also, and what is important, the content. And so, and what struck me in group 2's focus that I don't see in our recommendations, which it's just hit me, is shared decision making. That functionality has to be there, you know, from a care coordination standpoint, and we don't have recommendations about functionality in that area. So yay, group 2 for calling that out. I think it's critical.
And Alexa?
Yeah, I was just going to echo that group 1. Is there a way to put my hand down?
I got it.
That in the beginning, I was thumbs upping everything that Jerry was saying because our group had talked, you know, a lot about that, seeing that we had a lot of recommendations and bullet points, kind of a functionality of clinical and administrative use, but that there really wasn't a lot of patient use in there. And we called that out a lot, that there wasn't a lot of patient voice and a lot of, in particular, the shared decision making, and, you know, also the piece of not losing, you know, complete control, so to speak, from a patient or caregiver side of what gets shared, and not just automatically pushing everything and everybody knowing where you've been constantly, and allowing some of this sharing can be a burden both ways, to not have access to it and then be a burden to share it with, to have to share it with other health systems and other providers. But sometimes too much is shared and doesn't need to be shared, and that also becomes a burden for the patient too. So I thought it was interesting how we had a lot of the same discussions, you know, in both groups.
I was so excited.
Just add the other
what we
piece
did.
that Kyle in our group, Kyle, having you there was, I think, really meaningful for me, in that, adding what is right now and more context related to patient portals, because as we're learning about, fire and APIs, knowing what's happening on the patient side as well was really very helpful. So bringing that together, I think, should be an important part of our report.
Yeah, that's really helpful. And I think one of the things that I would like to do is follow up, like I mentioned earlier, with maybe Kyle and Joel offline, see what makes sense to kind of make sure. We certainly want the report to be grounded in the current state and where things are going, but see what makes sense to bring back to the committee too, as it could be helpful for, especially when we get to like the measure development and kind of thinking of those pieces and moving towards that more digital electronic or digital quality measurement.
Yeah, I agree. And I think it can also sort of inform a lot of the work that's being done in terms of the sort of transformation of measures right now. And I think you're all aware that sort of measurement as we know it is going to change in the next few years. And so really important to be thinking about sort of where those gaps are. And one of the, we just discussed, that there really isn't like a implementation, HL7 implementation guide that deals specifically with patient-reported data. And so I think there are some, identifying those gaps will be really critical to support that future measurement.
And Rich, were you going to say something?
Well, actually, I was. Kyle just said that, but maybe I'll tell you why it caught my attention. The statement, Kyle, that you made just before I went into the breakouts was really, really cool. And maybe I'll feedback. What I heard was ONC and CMS are working on this directionally. The work of this committee is not redundant or marginal, but that in fact, an intentional alignment would be desirable, because it sounds like ONC and CMS are not saying, what are the outcome measures? And so I want to call that out to the group. This is really, really cool. We don't have to come up with a fancy report that gets ONC's or CMS's attention. It sounds like for their work to ever have a measurable impact, this committee's work and the stuff that will follow our efforts is really an incredible opportunity, which circles back to thank you for the people that are bringing the family and patient and caregivers' voices. So Kyle, am I over?
Yeah, no, I don't think you, I'll pinch myself, but I think you're right. I think the timing, having done this for a decade now, I think the timing is pretty remarkable in terms of, what this committee is doing right now and government efforts. So I think yeah, you're spot on.
Any other final thoughts, comments, concerns? Hearing none, I will go ahead and turn it over to Victoria.
Thank you, Chelsea. I will now go ahead and open it up for public comment. If you would like to share, go ahead and raise your hand or use the unmute, or if you're on a phone line, go ahead and unmute yourself. And we'll allow for a few more moments in case you're having trouble unmuting yourself. Don't see anything in the chat or any raised hands. Okay, I will go forward then with next steps. Okay, so just as a reminder, you can submit any additional input on the ideal capabilities and capacities of EHR via email to our project inbox, which you'll see here below. Our next web meeting will be held on Tuesday, February 8th, 2022 from 2 to 4 p.m. Eastern Time. Please be sure to save the date for all of our web meetings. It will be held on the Zoom platform again. And feel free to contact the project team with any questions or if you do not receive any of our meeting invitations. I will pass it back to Chelsea.
Great. Thank you so much, Victoria, and thank all of you. We really appreciate the time that you spent and the great conversations, although I've only heard one half of it. The report out was really helpful from the first group. We are anticipating doing breakout groups again for the next 2 web meetings. So if you have any thoughts, comments, or feedback about how that went, please let us know so we can incorporate that hopefully in February, but if not, definitely in March. And like I had mentioned previously, our next meeting will be focusing on SDOH data collection and how that can be used, a little bit on the actual data that is collected, a little bit more on the use and the implications for measurement and care communication and care coordination in general. And then our last meeting, or not our last meeting, but our meeting in March will be focused a lot on measurement and really trying to leverage EHR source measures to really move this field forward. So if you have anything to share, please let us know. But otherwise, I will turn it over to Jerry and Rich for some closing remarks. I think I started with Rich, so we'll started with Jerry, so we'll start with Rich and end with Jerry.
Well, I hope that people feel the progress. We're putting one foot in front of the other with this journey. I'm particularly really excited that there are other portions of the universe of stakeholders, in particular our federal liaisons that are working on this. So I am really grateful for the depth of the contributions. Sue Ellen, Shay, thank you for your comment in the chat. We thought long and hard about the breakout groups, and to the NQF staff, thank you for making that happen flawlessly. I am also really excited about the next meeting where we're going to get more deeply into social determinants of health in the work. So I hope that each of you has a sense of the momentum is building towards some really clear recommendations that can be time bound. So thank you for everyone's engagement today. To you, Jerry.
I think you said it perfectly, Rich. I think we're making great progress. I am seeing that we're bringing together some really important movement context together with our recommendations. And I too would like to thank our whole committee. Was a wonderful session. And if you do have recommendations for the breakout groups, how to make them better, more effective, please put them forward. Thanks so much to NQF. You did an amazing job in preparing our committee for this work, and for our federal partners. It was wonderful having you engage so deeply with us today. So looking forward to our next meeting.
Great, thank you both. And we will be sending the summary of this meeting as soon as it's available. It should align just before our next meeting. There are a few different steps to that, but we'll make sure you get that. And then we are anticipating doing the breakout room worksheet again, so you're able to come prepared. So similarly, if you have any feedback on that, definitely let us know. But thank you, everyone, and we will see you in February.